summarizing the evidence from questions to evidence. You will remember this slide from one of my earlier talks about thrombolytic therapy. And the point of the talk was that the answer was in at this point, and when the answer was in at this point, most authors were recommending either saying not mentioning or calling the treatment experimental when the answer was probably in, and it took a decade for people to finally get the notion that thrombolytic therapy reduced deaths after myocardial infarction. This story ends at 1990, and although I could tell stories of problems, perhaps not as bad as this. And the reason is that in 1990, you started to have the advent and wide dissemination of systematic reviews and meta-analyses. And I would suggest that if the experts at this point had had systematic reviews and meta-analyses available that showed them a 25% odds reduction with a very low p-value and a confidence interval a long way from no effect, that you would have seen everybody over here recommending the treatment rather than the discrepancies that you have seen. So systematic reviews seem to be crucial in terms of getting the experts to understand the evidence and to make the appropriate recommendations. So, what makes a systematic review systematic? What makes it systematic is that it will stop all the problems that were going on here, where you had these diverse recommendations from experts a decade behind the evidence, and in the lidocaine example I presented, contradictory to the evidence. So why did this happen? The people making the recommendations may have had unclear or too broad questions, had unrepresentative sample of studies. I think that was a big problem. Were unable to differentiate studies with high and low risk of bias, and would make biased inferences on the basis of their preconceptions. So what makes a systematic review systematic is it brings in strategies to deal with these problems. With respect to unclear or too broad questions, explicit eligibility criteria, Roman has introduced you to criteria that define patients, interventions, comparator outcomes, and also methodologic eligibility criteria, often restricting to randomized trials. With respect to unrepresentative articles, explicit eligibility criteria help with that, as does a comprehensive search and duplicate assessment of eligibility. With respect to high risk of bias, methodologic eligibility criteria, like only including randomized trials. In the randomized trials, making a risk of bias assessment, for instance, looking at blinding or completeness of follow-up, and making that risk of bias assessment, doing it in duplicate. With respect to biased inferences, if you have a meta-analysis saying a point estimate and confidence interval, that limits the extent to which you can spin your data, and, as we will discuss, a formal rating in the confidence of your estimates. Bottom line, previous expert recommendations went wrong because of these problems. What makes a systematic review systematic is it puts in safeguards to deal with those problems. Sometimes people get confused between a systematic review and a meta-analysis. Systematic review is explicit PICO eligibility criteria, comprehensive search, assess risk of bias, do everything in duplicate. A meta-analysis is when you pool the data across studies for a single estimate. You can have a systematic review without a meta-analysis. If you pick your studies from your file drawer and don't do the systematic review, you can do a meta-analysis. The most informative is the intersection set, where a systematic review is done and concluded with a meta-analysis. So, most of the systematic reviews you see will address questions of therapy, very often focusing on randomized trials, sometimes on observational studies, but more and more you are going to be seeing systematic reviews that look at questions not of therapy but of prognosis using observational studies, and of diagnosis using diagnostic test designs. So I'm going to go through some of the components of the systematic review. Here's an example of a structured clinical question. So the eligibility criteria, here's unstructured: impact of acupuncture with tension headache when compared to usual care placebo. That breaks down efficiently into the PICO: patients with tension type headaches, acupuncture, 3 possible alternatives, and the outcomes related to number of headaches and functional and quality of life limitations. I mentioned methodologic eligibility criteria. That has to do with risk of bias. You can have very high likelihood of bias, or you can have studies that are completely protected against bias. So, for instance, randomized trials clearly protect against bias because of confounding. They're better off than cohort studies, but they may be unblinded, they may be blinded, or they may lose still a lot of people to follow-up, or they may be blinded and virtually complete follow-up. So there is this continuum, and if you have enough randomized trials, seldom the case, if you have enough well-done randomized trials, you may restrict yourself to randomized trials blinded and 99% follow-up. You're right up here. Don't have to worry about any risk of bias after that. All your eligible trials will be low risk of bias. Or restrict to randomized trials with blinding. Well, there's still possible gradient and loss of follow-up. Or only take randomized trials. Well, now your randomized trials may be unblinded, lots of loss to follow-up. So you've got a possible range of risk of bias. Or you don't have any randomized trials, you're way down here, and your risk of bias is much greater. So, one wants, the next criteria for a trustworthy review will be a comprehensive search. A comprehensive search is going to include electronic databases, hand searches of key journal, reference lists of retrieved articles, and efforts to deal with publication bias. So you have a danger in any systematic review that there are unpublished studies out there which yield different results. Ways of doing that: contact with the lead authors, look at to see what they know about what's not out there, conference proceedings, dissertations. So various ways. So one wants a comprehensive search, ideally considering the issue of publication bias. So here is the process that systematic reviewers typically go through. They look at potentially eligible randomized trials defined by title and abstract screening. Sometimes, not unusually, sadly for the systematic reviewer, there may be literally thousands of these. So you get rid of the titles and abstracts that seem that are not going to be eligible, and then you pull full text articles of anything that might be eligible. Even typically a relatively small proportion of those are eligible, and you finally have selected articles for your systematic review, some of which, sadly enough, may not provide the information you need to do a meta-analysis, and there may be an even smaller sample down here. So very much a funnel, a very large number of potentially eligible. You have to look here to ultimately end up getting everything that you want, every eligible article for your final study sample. This is the way the Cochrane collaboration, which is an organization dedicated to doing all the systematic reviews of randomized trials known to humankind, the way they will present risk of bias. Green means good, low risk of bias. Yellow means uncertain. Red means bad, danger, high risk of bias, according to these criteria. So one way is presenting by the study, and you can conclude here, Goodwin is low risk of bias, very nice, meets all criteria. Saunders, on the other hand, a lot of skepticism. You can also present that presented it by study. You can also present it by blinding, subjective outcomes, blinding, mortality, loss to follow-up, other sources of bias. And here you can see everybody did adequate sequence generation. Not everybody concealed randomization, some blinded and some didn't. So this is the same presentation, same data as the previous slide, which presented by study, this presented by sources of risk of bias. So, data synthesis. We would like ultimately to have a systematic review end off with a meta-analysis, and how might studies summarize the effects. So they can summarize the relative effect, risk ratio, odds ratio, or hazard ratio are measures of relative effect. And we could have measures of absolute effect. Should studies summarize by relative and absolute? And at the end of, I think, my first talk, where we pointed out that relative effects can give hugely inflated impressions of the effectiveness of a treatment when the absolute effects are small. Victor also emphasized that with small study effects. And the question was, should we outlaw measures of relative effect and stick to what's important to patients' absolute effects, like risk difference? Well, just to make clear, absolutely clear again, what we mean by relative effects: control 10%, treatment 5%, versus control treatment 2%, treatment 1%. Both of these are 50% relative risk reductions. 10 to 5% is a 50% relative risk reduction. 2 to 1 is a 50% relative risk reduction. But the 50% relative risk reduction in the first represents a 5% absolute treatment effect, the second a 1%. Once again, large relative effects may reflect substantial absolute effects, or they may reflect trivial absolute effects. So why do we bother about relative effects? We bother about relative effects, and that's what we present typically primarily as the first, that's how we do our meta-analyses, because the world works like this. Consider population 1, a 30% event rate in the control group, 20% in treatment. That is a 33% relative risk reduction, a 10% absolute risk reduction. Population 2, same underlying condition but lower risk, 10% event rate into control, 6.7% in treatment, 33% relative risk reduction. And same underlying condition, but a low-risk group, 3% to 2%, a 33% relative risk reduction. That is the way the world works. Relative risk reductions tend to be constant across risk groups, and if relative risk reductions are constant, that means that absolute risk reductions are going to vary, and if there's big differences in baseline risk, the absolute risk reductions are going to vary. So if we used, say, this 3.3% from the intermediate group, that would be very misleading either for population 1, which has a big absolute effect, or population 3, which has a trivial absolute effect. So we need to do our meta-analyses of relative effects, because relative effects tend to be constant across subpopulations. But then, when we have to decide whether our patient is population 1 with a high baseline risk and a big effect, population 2 a moderate baseline risk with a smaller effect, or population 3 with a small baseline risk and a small effect, we'll be very inclined to recommend a treatment in population 1, less so in population 2, and perhaps disinclined to recommend the same treatment in population 3. So, we need to distinguish between whether the systematic review was well done or whether we can trust the results. You can do a brilliant systematic review, comprehensive search, well-defined PICO, assess risk of bias, do everything in duplicate, and still have low-quality evidence. Why? Because garbage in, garbage out, no matter how well you process the garbage. Many systems are available for rating the quality of evidence. The grade working group started in 2000 and has developed a system which was first published in the British Medical Journal in 2004, a 6-part series of the BMJ in 2008, and a 16-part series, this one designed for systematic reviewers and guideline developers, starting in 2011. And there has been great uptake of this particular system, adopted by, for instance, World Health Organization, American Thoracic Society, the American College of Physicians, the Cochrane Collaboration, NICE in the UK, Up to Date, Dynamed. So there are over 100 organizations worldwide, including prestigious ones and ones very much used by clinicians. So a system that has been, we'd like to believe, has been taken up by this because it's very well thought out. How does it work in terms of quality of evidence? Randomized trials start as high quality evidence, but they needn't stay as high quality evidence. Unfortunately, these randomized trials may be at high risk of bias, have inconsistent results. The patients studied may be different from the patients we're interested in. The sample sizes may be small, as P.J. Devereux pointed out, with wide confidence intervals, and they may be still subject to publication bias. Observation studies start as low confidence, but they may be rated up and, in fact, may end up with high quality evidence. So with respect to randomized trials, they may be rated down to moderate, low, or very low. Observational studies may go from low to very low if they have those problems, but for things like insulin and diabetic ketoacidosis, chronic hip osteoarthritis and hip replacements, dialysis for patients with renal failure, large treatment effects leave us, or very large, leave us with high certainty that the treatment effect is real and substantial. This is the way GRADE presents the summaries of the evidence. This is the POISE, the data that included POISE that P.J. Devereux talked about, beta blockers in non-cardiac surgery. Myocardial infarction, over 10,000 patients, no problems in each of the reasons for rating down, high quality evidence, a 29% relative risk reduction translates into 15 fewer myocardial infarctions in 1,000, and you see the confidence interval. Mortality, no problems except imprecision. Why problems in imprecision? Death rates increase, as Dr. Devereux showed you, by 23%, but a confidence interval from essentially no effect to a 50% increase. Well, we'd think very differently if this were the truth versus this were the truth, so we rate down our certainty or quality of evidence for imprecision. If that is true, it's 5 more deaths in 1,000. Stroke, no problems, high quality evidence. Unfortunately, a doubling of the risk of strokes, 5 more strokes in 1,000 people. So this is the way GRADE summarizes the key evidence. So, in conclusion, experts before the era of systematic reviews and meta-analyses, experts were disagreeing with one another to a great degree. They were years or decades behind the evidence, or they were making recommendations that contradicted the evidence. Systematic reviews have, to a considerable extent, systematic reviews and meta-analyses have remedied that situation, and we need these systematic reviews for optimal use of evidence in patient care. What do we mean by a systematic review? It's systematic when it has characteristics that include a structured clinical question following typically PICO, a comprehensive search, and duplicate assessment of things like the eligibility decisions and the risk of bias. A optimally done systematic review will also summarize the quality of evidence. Certainty of evidence is a synonym. And ideally it will do it using GRADE criteria, and it will tell you that the quality of the evidence is high, moderate, low, or very low. And that will help you to decide how to use the evidence. Ultimately, you want a succinct and informative tabular summary of the evidence and the evidence profile that I showed you with each outcome, the magnitude of the relative and absolute effects, and the quality of evidence is, we think, a very good way to do that.